Dr. Aaron Horne Jr. is an interventional cardiologist, peripheral vascular disease intervention structural heart specialist of the Cardiac and Vascular Interventional Group, Dallas, Texas.
Good afternoon. So first and foremost, I really want to make this point. I'd like for everybody to give the Balm in Gilead a standing ovation. And the reason for that is multifactorial. One, not just for putting on programmings such as this over a 4-year period of time, but I don't know if you guys realize what a huge accomplishment it is to receive a longitudinal grant from the CDC. You know, on an individual basis, that's what gets somebody tenured professorship or an endowed professorship. I'm serious, that's a huge deal. And let me tell you why. You know, I think a lot of us have been on committees and where we have a conference call. Dr. Duncan and I were talking about this earlier. We have 4 conference calls a week. One's at 6:30, one's at 7 o'clock, right? And after that conference call, you got another conference call, and you never figured out what you talked about in the first conference call. And too often, we have these meetings and nothing comes from it. So to have a grant like that where you can have longitudinal, tangible programming, that's what this is all about. So I hope this catches your attention. If there's 3 take-home points, and I don't need to go into all of the slides, this really struck me a little bit over a year ago. I think that, first, let me ask you, how many of you guys have heard of peripheral arterial disease? So that's about half that have not. And I really, truly believe that the church would be in mourning if they realize what a big problem this is. Let me give you a quick example. How many of you guys have heard of heart attacks? That's a serious question. But that's the point I'm trying to make here. If there's nothing else that I get through to you. As a cardiac and vascular society, we've done a very good job educating people about heart attacks, right? If you're having chest pain, people run into the ER, you know to call somebody, you know, and you should, that something might not be right, right? But at least half of the people in this room have not even heard of peripheral arterial disease. So let's take a half a step back. So the aorta is the main blood vessel that takes blood to every single organ. Your heart, your brain, your legs, your kidneys. So come to figure, if you know somebody that has coronary artery disease and it's a part of the same blood vessel, then it seems to chance that you might have blockages in your legs as well. But because we as a healthcare community have done such a horrible job, and I truly believe that, communicating the importance of this disease state, this is what we're resulted in right now. So we know that more than 20% of healthcare spending is for people diagnosed with diabetes. And we know that PAD amputations are rapidly increasing, and they disproportionately are occurring in patients that are both diabetic and hypertensive, okay? How many of you guys heard of the American Heart Association? Okay, so we just had a big conference in Anaheim, California, and we came out with some new blood pressure guidelines. You guys familiar with that? So now we lowered the cutoff point for being diagnosed with high blood pressure. And we also know that according to the AHA, more than 50% of African Americans are now diagnosed with having hypertension. And I think that, again, it was Mr. Simmons whose story, you know, they always say that a picture's worth more than 1,000 words, because when he said, again, he went blind for a second, that made you catch your attention a little bit, right? And it's easy for me to bring up words such as hypertension and diabetes, but the question is, what does that lead to? It leads to blindness. It leads to losing one's limbs. So the story with PAD, and how am I doing on time? The story with PAD is compelling, and I want to try to really communicate this to you in a way that sticks with you, okay? The problem is that 50% of people in the United States get their legs cut off without ever having pictures taken to see whether or not something can be fixed. So let me try to say it a different way. If you had a heart attack, right? How many of you guys have loved ones that have had bypass surgery or stents? Right? You know that if you have a heart attack, first question you're going to ask somebody is, can you fix it? Can you open up a blockage? Can you put a balloon or a stent or something in there? A medication? But if you look at this slide right here again, we have patients that have visits with peripheral arterial disease and leg amputation in 2011. Look at that. And we see that now we're starting to talk about peripheral arterial disease, and a lot of it, to be quite frank with you, is because of the economics of it, okay? But these amount of visits of patients that are coming in with PAD that's already been deemed too late in its development to be treated with revascularization, and instead we go directly to amputating them. And so again, the Balm and Gilead figured this out as well. There are certain areas that need to be treated more disproportionately than others. If we look at where the prevalence is in terms of leg amputations, it's in the South. They doing okay. I lived in New York. I'm telling you, people eat quinoa for dessert. Ain't no PAD out there. You go to the West Coast, people aren't losing their limbs. But where I live, where I work in Dallas, Texas, look at this. The color of the circle, the ratio between major amputations and revascularizations. So if you got a smaller circle, right, then the smaller circle gives you the number of annual major amputations for each hospital across the United States. The color of the circle gives you the ratio between major amputations and revascularizations. So if you live in the blue areas, you have less amputations relative to trying to fix something first. Where if you have red circles, it gives you an environment where you have more amputations relative to revascularizations. And Texas is a big state, but I can tell you there's more red there than any place else. So if you look at this slide, again, I mentioned to you that 50% of people in the United States get their legs cut off without first having any pictures taken to see whether or not something can be fixed. African Americans are 4 times more likely to get their legs cut off than their Caucasian counterpart. The church should be in mourning if they knew that this was occurring. People don't know. And again, I bring up the hypertension guidelines again. Who are the people that are getting their legs cut off? Patients that have hypertension, diabetes, and renal insufficiency, and I couldn't agree with you more. The data supports it. The patients that are at greatest risk of having poor long-term outcomes, regardless of what their treatment modality is, are patients that have end-stage renal disease and are on hemodialysis, right? I just told you that more than 50% of African Americans are now going to be diagnosed with hypertension. We just showed you the degree to which diabetes leads to amputations, and they obviously disproportionately affects the Black community, in addition to the Latino community. This conversation is obviously a robust conversation, and it's one that we should continue to have because it also affects rural areas that have less access to a lot of the technology that we now have available to us. Because, to be honest, even though I made light of it to make a point, I wasn't making light of it, but I was trying to bring it to your attention. But the reality is, in the world, we don't treat heart attacks with balloons and stents. We use medications. People live 5 hours away from a hospital that can do those treatments. But I was sure hoping in the United States we can figure out how to get this treatment to folks that we know is just common sense. But this leads to a really important point that I want a couple take-home points. So, I think that we should acknowledge that there's a problem, right? We know that, and this is a fascinating point, the fastest growing population in the United States are people that are 85 years of age and older. Why is that important? Yes, I think we all agree that the church is the backbone of the black community. And I grew up, again, with a grandfather who was an AME minister, and I remember him always telling me, 30. If you live life the way you're supposed to and you made it 70 years, then that's God's blessing on you. And I'm not here to dispute, obviously Bishop Morton will be here later to give you the scripture, but I would tell you is that we actually, God has blessed people such as us and all of us to become learned and to be able to, because of clinical trials and because of drug development, to actually figure out how to not just prolong life, but enable us to have improved qualities of life. So when you actually are 75 and 80 and you're slowing down, don't just say it's because you're 75 and 80. Ask questions. The most important thing that I can encourage you to do today is to be your own biggest advocate, okay? Healthcare is a consumer-driven environment, okay? And secondarily, we obviously hinted at a very important topic, and I showed you this data earlier. And again, the reality is PAD, and I'm going a little bit more quickly here because I want to make sure that we do have time for questions at the end. But the, again, take-home point with peripheral arterial disease is it actually has a more significant mortality associated with it than people that actually have coronary artery disease, okay? This is the point I want to make. Statistical discrimination. Why is this happening, okay? The question was, again, do we not trust the medical community? I think that actually still is a big problem. We still need more black and brown doctors, okay? And we know that statistical discrimination means that, and this is, again, the gentleman I was very impressed with, Kendall Simmons. He was, I'm uncomfortable saying he was misdiagnosed, but statistical discrimination says that we treat you based on how our interactions with other people that look like you have been. So let me try it a different way. So statistical discrimination means that if I've had a difficult time getting a patient to agree to my treatment recommendations or me telling them what I want them to do, then I don't think that me trying to work as hard with somebody that looks like them is worth my time. No, the data shows it right here, guys. This is published information, okay? We know that African Americans and their Caucasian physician counterpart acknowledge to having more uncomfortable interactions with those patients. And that matters. It leads to, in other disease states, patients refusing life-saving therapies because they don't trust the person doing the procedure. This is important, right? So, but we all have been told, don't ever give somebody else that much power over you, right? So again, be your own advocate. If you're not comfortable with that particular provider, then you ask for another one, all right? And you keep on asking. You ask for the patient advocate that every hospital has to have, okay? But I also want you to remember this. I've been around too many really smart people, including my wife, who want to play WebMD. I'm serious, I've had patients, this is not funny, because there is a problem. We're losing our legs, right? We're dying from this. But don't come in and say, yeah, do you have chest pain? I think that's just indigestion. I mean, come on, let me figure that out, okay? But the only way you can do that, again, is to have a relationship with your provider that you trust, okay? So people like my colleague here on the front lines who are the family physician, the nurse practitioners, the physician assistants, the nurse educators, the health ministries, right? These are the people that are able to be advocates to ensure that we're actually to keep people and families intact. And the reason why this is going to be and is more important, not stating that, and I think that the grant from CDC shows that a lot of our governmental agencies are aware that things have to improve, but a lot of that's driving this is cost. If you look at how much more expensive amputations are compared to getting something fixed, because if you get an amputation, you know what? You're not going home. You're going to a nursing home, you're going to rehab, prostheses, lost wages. It's a very expensive disease state. So, I think the take-home point is, we can do something about it. So let's make sure that we're being our own biggest advocate. Let's ask questions, and I hope that just sometimes a picture's worth more than 1,000 words. This is what happens, and I have too many people that come in 5 months later and they say, oh, well, I bumped it 5 months ago, but I just figured, again, it wasn't anything. But this is what it can lead to. So I would absolutely demand, as a patient, if you go to a specialist, a heart and vascular specialist in particular, we need to get back to the basics. We've gotten a little bit too cute. They need to take off your shoes and your socks. There's no way they can examine you effectively without doing so. You need to take your purse, your coat off, and your shirt in order to do a proper cardiac and vascular exam. I never forget, I was in New York in training. I go into a lady's room. She's been there for over 15 hours in the emergency room, and I smell something. She had a big necromatous mass on her breast. Some of this stuff, again, is just low-hanging fruit. All right? So if there are other questions later during the Q&A, happy to continue this dialogue. Again, thank you for the invitation, and congrats again on the great work you do.